So, Dr. Kang, when is the sweet spot to introduce that drug? And it's a two-part question. Also, I want to also get into like, do you have any problem getting it covered by insurance?
Yeah, two really good questions. The best time to introduce Neratinib, that's such a fraught, I think, question, and it's of course going to depend on your discussions with the patient and sort of where you think it's sort of appropriate to bring into the conversation. Like certainly when you're first talking about neoadjuvant therapy, I mean, there's such a long road of treatment ahead. I think it doesn't really register even if you mention it. I mean, sometimes you're at a point where even talking about the year of adjuvant trastuzumab-based therapy doesn't really register. So I think you have to sort of read your patient. But I also know that mentioning Neratinib, just as you're finishing, 1 year of trastuzumab or TDM1, et cetera, is not the right time, because that's when patients are sort of ready to celebrate and cut the cord. And, you can't say, okay, let's do another year of a drug. So it has to be somewhere between that. And I find that I like to do it where, let's say, we're getting on adjuvant Herceptin Perjeta, we're getting on adjuvant TDM1 especially. You've had this discussion of increased risk or CNS metastasis. Once they're sort of steady on their TDM1 or their Herceptin Perjeta, then I say, hey, you've been on this drug for 3 months now. We've got, let's say, 6-8 more months left. When we finish, I want you to know there's an option for you that we're going to continue to talk about later. There's a pill that you can take for an extra year. It's, I think it's key to mention that it's an option to put that sort of patient ownership into this decision. And I like to mention it then, because then we've had a couple discussions by the time the year finishes and they're sort of ready to make that decision.
Yeah, I think like you said, it's important to start early. What I like to do it is that, like Dr. Burhare, I celebrate my past CRs. I absolutely do. But I leverage that celebration to offer Neratinib. I'd be like, see how happy we are right now? I want to keep you there. I don't want the cancer to come back, because if the past CR patient, if they're going to reoccur, where are they going to reoccur? In the brain. 4 out of 5 of those patients occur in the brain. So I tell them I have a drug that can protect the brain. And that's where I offer it. Now, the patient with residual disease already understand that they did not eliminate that cancer. And this is where I also introduce the 7%. Like I want them that we're going to do TDM1, but there is 7% chance despite TDM1. But guess what? I got you. I have a drug for you after to reduce that risk to less than 1%, hopefully. So that I leverage those meetings to present, because the sooner you present it, it's in their mind, they know it's coming. The later you present it, they're ready to finish. Right. They see the finish line. You're not going to take that away from them at that moment. Yes. So I like starting early.